Welcome everyone. I'm here at the World Congress on Pain 2022 and I'm standing here with Professor Dr. David Rice, who is an Associate Professor at Auckland University of Technology in New Zealand. Hi David, can you first maybe for our viewers briefly summarize your main research interests?
Sure. I'm interested in the mechanisms and management of chronic pain, with a particular focus on post-surgical pain and also musculoskeletal conditions.
Okay, yeah, thank you. So I saw that in 2018 you published a paper about predictors for persistent post-surgical pain in patients undergoing total knee arthroplasty. What were like the main findings of this paper?
Sure. So we followed about 300 patients through their surgery, undergoing a primary unilateral total knee joint replacement. And we were interested in what are some of the factors that might predict their persistent pain at 6 and 12 months. So we measured a bunch of things before surgery, including some clinical and demographic factors like their age and their gender and their BMI, the number of comorbid pain sites they had, and then some psychological factors, and including catastrophizing and expectation and depression and anxiety, some QST-based factors, some genetics, and then some intraoperative factors, and also the acute postoperative pain. And we looked at all of those factors. We followed them for 6 and 12 months, and we worked out how many people developed persistent pain and which of those factors might help us to predict who developed moderate to severe persistent pain and who didn't. And what we found is similar to other international studies. About 20% of people developed moderate to severe persistent pain 6 months after surgery, and about 16% at 12 months after surgery. And the key factors that seemed to be important at 6 months were high preoperative pain, state anxiety, higher state anxiety, expectations of having more pain 6 months after surgery, and also higher temporal summation.
Okay.
And then at 12 months, similar factors were also important in terms of anxiety and expectation and high preoperative pain.
Okay, very interesting. And like you said, one of the predictors or two of the predictors were preoperative pain intensity and also temporal summation. I want to go a bit deeper into that. So why do you think it is specifically temporal summation, which is a correlate like we know for nociceptive facilitation, that was a predictor, and not, for example, CPM, conditioned pain modulation, like for the inhibitory mechanism? So
it's a good question. I don't really know. Certainly CPM in our study wasn't predictive, and temporal summation was, and that seems to be more consistent across the studies that have looked at those two measures. So temporal summation does seem to be more consistently a predictor of persistent postoperative pain. It may be because perhaps that's just a more stable measure. Perhaps the descending inhibitory pathways, our endogenous descending inhibitory pathways, are more dynamic and change over time. Could also relate to the fact that there are different methodological differences. So different labs use different ways of measuring CPM, whereas temporal summation seems to be a bit more consistent. So maybe there's some methodological variance there as well. And if you look at your protocol, do you think you use the most optimal way to measure it, or will you do it differently in the future? Which protocol did you use? Maybe that's also interesting to tell to the viewers. So in hindsight, probably we would do it a little bit differently. We used pressure pain, changes in pressure pain thresholds. So that was the test stimulus. The conditioning stimulus was a cold pressor test, but we used a parallel presentation. So we did the cold pressor test until people reached a certain pain level, and then we repeated the pressure pain test. And so maybe there are some differences in the way that other people have used different conditioning stimulus and have used a serial rather than a parallel presentation, and so maybe that could explain some of the differences.
Okay, thanks. So, like you said, you also identified predictors like anxiety and pain expectations, and also a lot of other stuff. Now, if you take everything together, is there like a recommendation that you would say how we can improve the clinical pathway for patients with or undergoing total knee arthroplasty?
Yeah, I think we probably don't know at this stage, but I think our study really is backed up by most of the literature in this area, which tends to show that it's a combination of preoperative psychological factors, and perhaps preoperative high pain intensity and evidence of sensitization of the nociceptive system that seem to be the most robust predictors of persistent pain. And so most of the intervention studies that have been done so far seem to have been more unimodal, so they've tended to look at, for example, one particular risk factor like pain catastrophizing and done a cognitive behavioral therapy intervention, or have looked at specific kinds of drugs that might modulate the nociceptive system, perhaps centrally acting analgesics. But what I think we should probably head towards is a multidisciplinary type of intervention that addresses both psychological factors and potentially addresses the sensitization problem, and maybe then we might get a stronger effect.
Yeah, and would you then say that we should actually do kind of a pre-screening and then see which interventions are useful for a certain patient, or? Yes,
I think if we were listening to Michael Nicholas's talk this morning, I think a matched treatment protocol might be optimum, but of course that's perhaps difficult to implement in practice. But I think matching the interventions in a biopsychosocial framework to the particular risk factors for that individual is likely to have the best effect.
Yeah, okay, thank you. A lot of work to do in that area, I guess. Thank you for the interview, David, and thank you for viewing.
Thank you.